So, good evening, everyone. We will be starting a topic known as corneal ulcers. It's an important question. The question comes like define corneal ulcer, describe etiology, clinical features, and management of the bacterial corneal ulcer. So, the answer to it is first we will define what is a corneal ulcer. Corneal ulcer is defined as any discontinuity of a corneal epithelium plus adjacent stromal infiltration of what? Inflammatory cells and necrosis. So it's basically discontinuity of the corneal epithelium with adjacent stromal infiltration of inflammatory cells and necrosis. So stromal infiltration by inflammatory cells and necrosis of it is the first point what we have to write. Next, what is a bacterial corneal ulcer? A bacterial corneal ulcer, the first part is etiology. Etiology has two things: prerequisites and predisposing factor. So the prerequisite factors are, first, there is breach in corneal epithelium, that is why we are calling it as an ulcer, correct? And second is the pathogenic infiltration of bacteria to the eroded cornea. So there is, we know there is, this is, if this is cornea, if this is cornea, we know that there is breach in continuity of the cornea, but the organism should go to that point. The pathogenic infiltration of the bacteria should be there to that eroded cornea. See, these are the two prerequisites. Next, what are the predisposing factors? Predisposing factor, the first predisposing factor is trauma. So trauma can be road traffic accident, assaults, agriculture injuries, or surgical traumas during any surgical procedures. These are traumatic injuries which will cause discontinuity of the cornea. Or it can be corneal aberrations like small foreign body sensation, misdirection of cilia, any constrictions, etc. can also cause the corneal injury. Or it can be because of the epithelium drying as seen in xerosis and exposure keratitis, or it can also be necrosis of epithelium known as keratomalacia. Fifth is desquamatization of epithelium. So it is basically leading to, as we know, desquamatization is leading to corneal edema, and the condition is bulla keratopathy. So we have to only by heart this thing. We have to by heart this whole thing about prerequisites and predisposing factor like trauma, corneal aberration, epithelial drying, necrosis, and desquamatization of epithelial cell injury. Now, the pathogens involved are Neisseria gonorrhoeae, Corynebacterium diphtheria, Haemophilus agibidus, Listeria, and Neisseria meningitis. This is basically a point which is optional to write because we are anyway gonna write the bacterial things ahead. So just you have to understand what are the predisposing factors. This was the first predisposing factor. Second predisposing factors were the predisposing factor which lowers the host resistance to these organisms. It can be use of topical steroids in the eyes. Some conditions use topical steroids. It can be diabetes mellitus. As we know, diabetes mellitus decreases the capacity of the body to fight infections. It can be use of systemic steroids or immunosuppressive drugs, which basically suppresses the immune system, and when immune system is suppressed, infections can run rampant, correct? Or it can be AIDS. AIDS is basically an immunosuppressive state only. So predisposing factors are this. Then third one is the causative organisms. So the common bacteria which are causing this bacterial corneal ulcer are Staphylococci, Neisseria, Streptococci, pneumonia, Neisseria, gonorrhea, etc., etc. You have to write this, but it is one of the most important things to write. It's a highlight point. You have to box it. Most common organism in generalized bacterial corneal ulcer is Staphylococcus, and when it is related to contact lens, it's Pseudomonas. Okay, now First part of the question was to get the etiology. Etiology we have done. This is an basic and an LAQ questions which can be asked in your exam for 10 or 12 mark depending on your institute. Next part of the topic will be what are the clinical features of this topic, or what are the clinical features of bacterial corneal ulcer. This was all about rectify. Everything was rectify. You can read it or rectify it. This is the concept wala part which you have to understand. See, keratitis symptoms are see. First, the patient will have photophobia. Photophobia is basically when light is exposed to the eye, he will have pain. So why? Because as we know from the anatomy of cornea, cornea has unmyelinated cells, unmyelinated nerve cells, which will get exposed on the corneal ulcer because there is erosion or breakage of epithelium. When the light falls on it causes pain. So it will be 5 things. First thing will be photophobia. Second there will be watery eyes. Eyes will be watery with a discharge present in it. We have to write discharge as well here. Next, there will be pain which is associated due to spasm of ciliary muscles. There will be pain. Then there will be hyperemic circumcorneal arteries. So there will be the redness. So this will lead to redness of eye, and there will be blurred vision because of corneal haze. In last topic, I told you about corneal opacities. So corneal opacities is base. So corneal ulcer causes corneal opacities. We have to understand it. So corneal ulcer causes corneal opacities. Okay, and the progression pathogenesis of it is in different lectures. I'm not going to discuss it, it's very lengthy. So the 5 things are photophobia, watery eyes, pain, hyperemic corneal arteries, and blurred vision, which causes corneal haze. Next, what are the signs of it? Symptoms are the things which patient experiences, right? Now what you will see here, we have to use scientific language like photophobia. Swelling of eyelids will be seen, which are in some cases blepharospasm. So it's basically blepharospasm. Sorry, blepharospasm can be from moderate to severe. There will be corneal ulcers in which is because we are seeing bacterial corneal ulcer. So bacterial corneal ulcer, how it will be? It will be mostly yellow in color, which I will discuss later on. Watery eyes will be hyperwatery eyes, and sometimes intraocular pressure can also be raised. So these are the signs. Signs are photophobia, swelling of eyelids, blepharospasm, corneal ulcer, hyperwatery eyes, and sometimes ocular pressure. Now we have to write this. This is also an important. This is which will get the mass specific organism, subspecific type of presentation of this eyelids of the bacterial corneal ulcer. If you just give me 3 minutes of this lecture, I will tell you how you are going to write this. See, understand it, it's very easy. So first organism which we are talking is Streptococcus pneumonia. Streptococcus pneumonia is most common generalized ulcer wala causing organism. It is the most common ulcer causing hypophion. I will explain to you in detail. It's basically, just remember, it is basically filling of anterior chamber of eye with inflammatory fluid. Okay, inflammatory fluid, anterior chamber of eye. It's sterile because it's bacterial. So what is the characteristic feature of Streptococcus pneumonia is it will be having one end. See this, it will have one end which will be healing, and one end which will be like, one end will heal, one end will be an active infection. So one will have active infection, one will heal. That is why it's important to know it looks like a snake. So it is known as serpiginous ulcer. Serpiginous, so it basically moves like this. It moves, or creeping ulcer. The first thing is streptococcus pneumonia. We are done. Most common and generalized, causing hyper. One end is this, one end is active, one end is healing, so it is called as serpentinous. Second is pseudomonas. Everyone knows from microbiome of second year, pseudomonas is green in color. It will get greenish discharge, anything greenish, so it is associated with greenish discharge. It is rapidly progressive and most commonly seen in contact lens users. We have discussed this. This is one of the most important topics, one of the most important NEET questions or MCQ questions which can be asked. What is seen mostly with contact lens users? We have seen in corneal abrasion here. In corneal abrasion, here you can also write contact lens. Contact lens can also cause corneal abrasion. Sorry for missing that point. Next, see, as you can see greenish discharge is seen. So greenish discharge of eye. Most common perforating ulcers. It is also the thing which will cause perforation. Staph aureus will form an abscess, and this abscess will be filled with pus. Okay? So there is formation of abscess and it is mostly marginal. So as we can see, it's marginal. So Staph aureus will form marginal keratitis and abscess. Staph epidermis. Staph epidermis, as we know, it's basically commensal organism. It's a commensal in normal flora of the person, but it can be seen attacking following a surgical procedure, for example, LASIK or keratopathy. This is seen if the surgeon has not maintained proper aseptic precautions. Maintained proper aseptic precautions. This is seen. Next, how do you manage the bacterial corneal ulcer? So we are done with etiology. We have done with features. Now we will come to the most important part: how you will manage it. So management of corneal ulcer is one of the most important parts, and it's very easy if you learn it like a story. See, management, immediate identification and eradication of the causative organism is necessary because it can threaten vision. It can also cause hazy vision, which can be dangerous, which can be threatening to the eye. So first we will do is clinical evaluation. Clinical evaluation, what we do when a patient come to us, we take the history. So history taking is one of the most important thing, because then and then only we can basically point out what is the etiology of the organism. Then we will do is general physical examination. If the person is anemic, whether he is well nourished, on this basis general physical examination. This is the basic part of the what you do in any OPD. What workup you will do when it comes to this? So the workup which you will do is, first you will check for corneal sensation from the cotton fab. If the corneal sensation decreased, you can tell that keratitis is either viral or neurotrophic keratitis. Okay. Then what you will do is you will stain the corneal ulcer. Now you will say, sir, why we are staining the corneal ulcer? We are staining the corneal ulcer to get the dimensions and the morphology of the corneal ulcer. Dimensions and morphology will help us to point out what type of infection it is. Okay. So to stain it, we use tropical 2% of fluorescent dye. Now how this tube is seen? This tube is like this. It is orange color pointed end. So this is given in eye and the patient is asked to blink, and this whole, basically what it does, this fluorescent dye will fill the epithelial defect. What do you mean by fill the epithelial defect? It basically recognizes the floor of ulcer. So when this is seen under blue light, we see a green fluorescence. So now I have made a mnemonic for it, OBG. O for orange, B for blue cobalt. When we see and eat under blue cobalt light, it is greenish in fluorescence. So OBGY, what we basically called OBGY. OBGY is a subject in 4th year, right? So mnemonic OBG. Now, the second stain which some people use is rose Bengal stain. Rose Bengal stain causes irritation, so it should be used with an anesthetic agent, mostly a local anesthetic, so that the person is more comfortable doing it. So, what it is just purplish in color. What we do is apply it is of it identifies mucin and dead epithelial cells which are peripherally present, as we know. So this too is called as filaments. So in filamentous keratitis it is only done. It is not done because of its irritation. Mostly when asked, you have to write it is tropic, it's fluorescent dye. Now this Bengal, 1% of tropical solution is used. Now we have stained it, we have known the direction and morphologically. Now we will identify the organisms. We will identify the organisms. We will identify the organisms. How? We will identify with the help of corneal scraping. Corneal scraping is done with the help of a 15 BP blade. This 15 BP blade helps in scraping of some part of that ulcer. So after scraping, we will either stain the ulcer, we will culture it, and PCR for rare diseases. We have to do all the three things. When we have learned this in microorganisms, it's a general microbio in second year itself, in general microbiology. So if the organism is bacteria, which stain we will use? Of course, gram stain. Gram positive, whether it is gram positive or gram negative. And culture, we will use blood culture or chocolate agar, blood agar or chocolate agar. Why this is important? This is important to treatment purpose. It is important for treatment purpose. If it is fungi, KOH will be used. Sabrose dextrose agar will be used. That is SDA. And if it is Encanthamoeba, then I have made a mnemonic LAG-G. LAG means lactoferrin cotton blue, acridin orange, cauliflower white, and Gimsa. So the culture uses non-nutritional agar with E. coli, because Encanthamoeba basically loves eating this bacteria, loves eating E. coli. That is why it is important for you to understand the culture for it is non-nutrient agar. So how you will treat it? We have basically diagnosed it. We have diagnosed based on the workup, evaluation, etc. And if you want to increase the answer, you can also write key. We can do general examination, like we can do CBC, etc. Every other report you can find CBC, blood test, any deformities, molecular techniques which we have learned in second year answers. Now how you will treat the organisms? Treatment is very specific. If it is specific, so you have to write a definitive treatment. This is, you have to box it and write. It is one of the most important treatment. Vancomycin, tropical. You have to important emphasis on this word tropical. You have to give important emphasis on this word tropical. That is vancomycin with cephalosporin, which can be second or third generation. So how you will give it? That's the question. Every 5 minutes for 30 minutes. First thing. Every 5 minutes for 30 minutes. Every 30 minutes for 2 hours. Every hourly for a single day. 5 for 30, 30 for 2, hourly for a single day, 2 hours in day and 4 hours for night till it heals. Then you can use commercial eye drops. 5 for 3. Then it is 30 minutes for 2 hours. Then we have hourly for a day, and when 2 hourly for a day and 4 hourly for night time, until and unless it heals. Oral antibiotics can be given, but it is not used. If it is very severe case, it can be given. 1 dose of cephalosporin or ciprofloxacin is more than enough. It is, I think, so 750 mg. It is more than enough for the organism to die or for the course. Non-specific, first we will give cycloplegic drugs. Cycloplegia, you have to understand the word cycloplegia is the word which is used to basically relax the ciliary muscles. So to prevent the spasm of ciliary muscles, we have seen the pain which was in clinical features, pain for the patient was mainly due to the spasm of the ciliary muscles. So you have to use cycloplegic drugs like atropine. It also decreases the hypercongestion which is occurring in the cornea. So home atropine and 1% of atropine can be given. Systemic analgesics like ibuprofen and PCM म्हणजे paracetamol can be given to decrease the pain if the person is having a lot of pain. Physical can be, you have to take rest is necessary in every disease treatment. Rest is important. Hot fermentation and dark goggles can be worn. Dark goggles is also one of the most important things because photophobia, the person has photophobia means light exposure. If the person is exposed to light, he will feel pain. So because to prevent it, dark goggles are important. This much is enough for a 12 marker question of ophthalmology. It is one of the most commonly asked questions. Thank you.